So we're going to start with the panel comments of 5 of our additional panel members. Then we're going to go on to a discussion of general issues, and then we will go on to address specific questions related to the language of the guidance. So that's how we're going to proceed. So our first panelist is Robert Calif and from Duke University, and if you can speak for 3 to 4 minutes, and that would be terrific.
Okay, I have 6 quick points here that relate to what people have said. The first is that from a researcher's point of view, it looks like the world of research has moved on and ethics has stayed the same. That is, when I hear the discussions, a lot of it doesn't pertain to the most cutting-edge research, which is now being done. And these older notions of what doctors do, as John pointed out, just seem out of touch with the clinical reality that I see, not just in the U.S., but around the world. Second, as a result of the fact that research has moved on, I think it really is true that we're missing an opportunity to save a lot of lives because research is not getting done. And you know, when I started doing heart attack research, someone would roll in the door, you'd have to write on a sheet of paper what happened to the patient. The key punch existed, but there was no way to aggregate the information. It took forever, and thinking of doing adequately sized studies to change practice was not even in the realm of possibility for most people. Now, we have technological capacity to answer questions very quickly that are vital to people, and we're just not doing it because it's too expensive and so hard to do. Third, the Pillsbury Doughboy effect that Steve Hyman spoke eloquently about, which is related to point number 2, which is that optimizing one part of a system may in aggregate be bad for the whole system. And what I'm referring to there, I've forgotten which patient advocate, but there was an eloquent statement made about the degree to which data dredging is happening by insurance companies, payers, health systems, not necessarily to the benefit of patients, but to optimize the functioning of those systems from a financial perspective without ever telling people that it's being done. And I think I'm seeing in the empirical research a thread that people don't like it. And they actually would prefer to be informed about that part of what's being done to them as opposed to spending many more hours trying to deal with what researchers are doing. Point number 4, randomization. It is tough. But I've had the privilege of doing a lot of work with Google over the last 3 years, and what I didn't realize, and this is not trade secret, it's well known, how they do it is a trade secret, but nothing happens at Google or Facebook without randomization. When you do a Google search, you're on average participating in 6 randomized trials. And the point here is not that about consent from my perspective. The point is people who really understand what it takes to optimize a system have realized that to draw causal inference from small effects, you must randomize. That is to get the right answer. You must randomize. And when you deal with large populations and you're getting the wrong answers by using the wrong methods, you can hurt a lot of people around the world. So we have to get to the point of helping people understand what randomization is and why every other venture has moved beyond medicine in this regard. Quickly, the last 2. I've heard almost everyone say they're in favor of short consent, but the opposite is happening. I don't understand why the world of ethicists doesn't stand up and say, we've had enough of this. We've got to come up with a different system that gives people the short consent they want, but gives them access to the longer information if they want to see it. There is no technological limitation to doing this, and we could do it a lot less expensively than the huge amount of time it takes for a diligent person to go through the 10 to 12-page consent. Then finally, this is really all about learning health, and that it ties together almost every aspect. It's an IOM thing. The rhetoric of learning health is beautiful. In practice right now in America, we're going the opposite direction for a lot of the reasons that have been discussed here. And I actually think the discussion these last 2 days is very pertinent to the common ground there. Thanks.
Thank you, Robert. Now Valerie Castle, University of Michigan.
Hi, so I'm thrilled to be part of this panel, and I agree with absolutely everything Robert just said, and I think some of my comments will reinforce his perspectives as well as the perspectives of our eloquent speakers today. So I need to give you my context. I'm a pediatric hematologist and a pediatric oncologist, and for almost 35 years or so, I've been involved in the design, execution, and consenting of trials in neonatology with hematology and oncology. And so my perspective is very focused in those areas, but I would say to you that the advances in pediatric oncology that have been made through randomized trials have been nothing short of extraordinary, both in improving the survival of children with deadly diseases, but also removing therapies that have caused enormous consequences with late effects over their lifetime. And so to not understand that context, I think, in this discussion is probably not good, and I feel is very important. So research trial strategies that include randomization between care approaches that we've been using the term standard of care, to me, are really the approaches that allow us to look at our current best available treatment approaches in order to define new therapies that will better guide the conversations that we have with families around the decisions they make on behalf of their children. They're designed to provide new evidence. So as a consequence of that, I believe that a provider or a researcher or the provider researcher that traditionally does most of the consenting has 5 key responsibilities. The first responsibility that the investigator has is to clearly help the family, help the patient to understand their disease, understand and explain the current limitations in clinical practice and the current approaches to clinical practice that exist. That is our first and primary responsibility. Our second, when we're describing a trial and an opportunity to participate in a trial or to make that decision as an informed parent or patient, we have a responsibility to help the family understand the study design, the questions that are being answered, and the approaches that are being taken, including these concepts of randomization, in simple, understandable ways. And my experience tells me that that can actually be done quite effectively. Third, we have a responsibility to define the foreseeable risks, both of the standard of care that is currently being used, but also any investigational arm that's part of the treatment trial. And by that I mean we have to help families understand what the expected risks are, and not only what the expected risks are, but what are our strategies going to be to mitigate those risks and ameliorate those pains or ameliorate those symptoms. Those are implicit in our process of discussing the disease and how we approach the treatment. We next have an obligation to describe any rare, potentially catastrophic and very harmful risk. It would be unconscionable for me as a pediatric oncologist to not explain to families on particular trials that there's a less than 1% chance, but there is a chance that some of the drugs that I'm giving you could in fact cause your child to have a second malignancy. That is a requirement of my process of explaining to them and informing them about the disease and the limitations of the current therapies that we are utilizing. And finally, every investigator has to also create an understanding that I am describing for you what I know to be possible, but in no way can I predict every single outcome that might occur, particularly when there's a new intervention with a new drug or a new way of giving a compound in a trial. I agree with the investigators up on the panel and the experts today that we also have an obligation to talk about the benefits. And while I agree there is data to show that patients participating in trial may in fact get better, more careful care, I don't think that should occur, but I know that that exists. The real benefit is the concept that you are going to be part of creating new evidence. And in every informed consent process I've ever participated in, and I've never been able to do one in 79 minutes, it is absolutely clear that parents and families and patients understand the benefit of giving back to future generations, because that's indeed how we got to where we are today. And lastly, I think that the investigator has an obligation, if the patient doesn't meet eligibility criteria, or if through this informed discussion they choose to not participate in the research, it is our obligation to do the first part of this process right, the discussion about risks and benefits right and correctly and well informed, because at the end of the day, each of us has an obligation to do our very best to take care of the patients that are our charge and our responsibility. And so they should not get any different interventions with regards to understanding that you would not get if you weren't participating in the trial. I want to emphasize, although it's not really part of the discussion, I think, today, that there are some unique areas in medicine where the complexity of what we do is extraordinary. Take, for instance, a maternal fetal intervention, where an intervention is occurring in a fetus that could have profound effects for the fetus, but also profound and very different effects for the mother. The informed consent processing is very complex and very difficult, and that leads me to my final comment. In pediatric oncology, most of our consent forms are 50-plus pages. If they were 11 or 12, it would be a lot easier. They aren't. They're extraordinary, and they keep getting longer and longer and longer. And I've never read a consent form in my entire career that has captured all of the potential things that could occur in any one trial. Never, and there never will be one. So adding more is not necessarily good. So thank you.
Okay, Keith Fargo from the Alzheimer's Association.
Hi, good morning, everybody. I'm the Director of Scientific Programs with the Alzheimer's Association, and this has been a tremendously thought-provoking and very interesting set of presentations so far this morning, along with what we heard yesterday. I just have a few brief things I want to touch on. The first is the concept of informed consent, and I really appreciated the concept earlier that the form that we talk about with informed consent is not the same thing as informed consent. And I think that's very important to keep in mind because, as you mentioned, some of the forms are 50 pages long. I would venture to say that no one, perhaps anywhere, is happy with what informed consent forms look like, but we must be careful not to throw out the baby with the bathwater. So I think it's critical that even though no one likes informed consent forms, that the concept of informed consent as knowledgeable permission remain sacrosanct, and that we still have to, even if we don't like 50-page consent forms, we still must seek knowledgeable permission giving from potential research participants. The other thing is I've heard people sometimes talk about consenting patients as if consenting is something that you do to a potential participant rather than a potential participant knowledgeably giving their consent or their permission to be part of a study. And so I think that's important to keep in mind as well. And that gets to the concept of altruism, that most people, when they are given the chance to give their knowledgeable permission to participate in this kind of study, will, although there are some who would not. And there are some who, even if they are very willing to participate in this study, still hold very dear their personal autonomy in the sense that they have to give that permission. They want to be the one who gives the permission, which I think is critical from an ethical standpoint. The other thing I want to talk about is this concept of risk, and are the risks different between clinical practice and research? And I think that we heard a very good presentation this morning that started with the proposition that they are the same, but then gave a whole number of reasons for why they're not really. And I think I would agree with that. They're not the same, and not least of which is this concept of spectrum of risk. And related to that concept is there is a lot of risk in standard of care and clinical practice, and we're not very good about communicating with that or about that with patients. So therefore, why do we have to be so good about communicating that same kind of risk with patients in the context of a research study? And I don't think that that's a reasonable supposition that because we're not very good at it in clinical practice, we therefore don't have to be very good about it in the context of research. I think that potential research participants have an extra layer of protections, if you will, and that they're there for good reasons. And so you do have to be better at explaining risk of research than you have to be at explaining risk of clinical practice. And I think that gets to the third thing that I want to talk about briefly, which is the concept of individualization. And we've heard a lot about the fact that individual treatment may be something or individualized treatment may be something of a myth. But it's a myth that patients do have, and I think that patients are willing to cede a level of control to their healthcare providers in the context of individual care that they may not be willing to cede in the context of research. And I think that that's something that has to be respected. Then just as a final thought, one of the speakers really eloquently spoke this morning about the relationship of physician to patient versus researcher to patient, and whether that needs to necessarily be a different relationship or whether those two things are in conflict with each other. And the point was made that if what the physician is doing is providing care for the patient, and that's the research is based on caring for that individual patient, then it's not a different relationship. And I think that standard of care, which I would essentially agree with, but I don't think that's what we're talking about in standard of care research. I think that really gets to the idea of, I want to try this particular treatment course on this particular patient and see if that works, and if it doesn't work, we go back and try something else. That's more of sort of an experimental approach to an individual patient's care, which is different from, I want to find out what works for all patients or this entire population of patients. So I think it was a good point, but maybe doesn't necessarily apply to what we're speaking about today. Thanks.
Thank you. Okay, next, Ed McCabe from the March of Dimes.
Thank you. So the March of Dimes is a consumer-facing organization focused on healthy mothers and healthy babies. We want families to have the full information, to be fully informed, so that they can make what they feel is the best choices about participation in all research, including standard of care research. And in fact, we want that for the care of that patient as well. We want families to be fully informed. We need this research because in the past, our history is that we have protected certain groups, including women of childbearing age, 18 to 44 years, children, and particularly neonates. And this has created these therapeutic orphans such that the majority of drugs that we use are off-label. The vast majority of drugs in the NICU are completely off-label. Ampicillin is used off-label many, many times every day in the U.S. for children. The FDA recently hosted a meeting about the need for clinical trials in the NICU, so it's being recognized that this is an important area for research. And again, I'd emphasize what people have been saying, that there are serious risks of not doing research. When you do not do research on one of these subpopulations, every time you prescribe that drug, it is off-label, and it's an N of 1 in that clinical trial. And unless there are very significant side effects, you will not identify them with clinical trials with Ns of 1. We're concerned that the origin of this meeting and the guidance, and in fact the emphasis of risk in the guidance, could have a chilling effect on clinical trials, particularly standard of care research in NICUs. We have many experts here at this meeting, experts who have written on both sides of the controversy. We would just urge you, please, in your future comments, please, please encourage research for these therapeutic orphans. Do not discourage research. We need that research. There is risk to not having that research. So please encourage research as we move forward. Thank you.
Thank you very much. Okay, and our last panel speaker would be Richard Platt from
Okay,
Harvard
last guy.
Medical School.
I'd like to pick up where Rob left off, and that is with the learning health system, because I think that the trajectory that we're on now is puts the learning health system project in fundamental jeopardy. Just to give the capsule of what I think we mean by the learning health system, it is one in which active learning, which is research, is incorporated into the fabric of the delivery of clinical care. And I think that was well conceived and is should remain an important societal goal. And I'm deeply, deeply concerned that we won't be able to implement anything approximating our goals if we continue to think of research as a fundamentally different activity from providing high-quality clinical care. I think there are sort of two pieces to that. One is that I strongly believe that we need to think of quality improvement as research. That is, if you do quality improvement well enough, it's indistinguishable from research. And so we shouldn't accept low-quality quality improvement because it's easier to do. And the second is, although several people have said it, we can't overemphasize the distinction between clinicians having their patients' best interests in mind and their knowing what the best treatment is. And so the notion that there is extra protection afforded by an individual clinician advising a patient about best practice, when in fact there is ignorance about what best practice is, serves no one's interest. And it is important not to destroy patients' belief that their clinicians are going to help them. On the other hand, our persistent ignorance about what we're actually providing is really problematic, I think. So two kinds of recommendations. One is, in the spirit of thoughtful people can differ, I'll say, I think the standard for disclosing both risks and benefits in research should be the same as they are in clinical practice. Several people have said that clinical practice isn't where it ought to be, and I agree, and we should improve clinical practice. But in the meantime, we shouldn't make it very, very difficult to do research by holding it to a different standard. Second, I think we should know what those standards are by doing the kind of empirical research that we heard described yesterday and today. It's a great start. The things that we want to know are knowable. We just have to ask in an organized way, what is a reasonable standard to hold clinical practice and research to in terms of notification? The other major thing that I'd like to say is I think we haven't done justice to the importance of understanding how cluster randomization can both be critically important to comparative effectiveness research and to this discussion about what appropriate disclosures should be. 10 years ago last month, in this room, Rob and I were paired in a debate about what the future of comparative effectiveness research should be. And I have to say, Rob has held up really well in the past 10 years. But as is so often the case, we ended up pretty much agreeing with each other. But I made the argument for the EPO-CRT in that discussion, the embedded practical observational clinical cluster randomized trial. And I still believe that if the question is comparative effectiveness research, how well does a regimen work in actual practice, then the way to evaluate it is in actual practice, which usually means saying adopt a strategy of A versus a strategy of B, which is not what individually randomized trials do. So since I only have 3 minutes, I won't go through the whole argument of why I think it's a terrific thing to do, but I will say that I think that many of the issues, or I will say that cluster randomization overlaps individually randomized trial content much more than yesterday's conversation would have led us believe. Many of the therapeutic questions we're interested in, I think, could be better studied as cluster randomized trials. And so it's not acceptable, I think, to say that's a different set of issues around decision-making and consenting and informing. If the issues are good enough for cluster randomization, then they have to be good enough for individual randomization. I agree there's a lot of work to do on what's appropriate for cluster randomization, but in terms of the report from this workshop, I think it has to be flagged as the same set of issues that need to be resolved in a coherent way. So I appreciate the chance to put these comments on the record. Rob, maybe we can continue that debate sometime.
Thank you. This has been wonderful. And our panel, we not only have the benefit of all the wisdom that has been said at this panel, but also of yesterday's panel. So one of the things we're going to try to do in our questioning is to integrate kind of what we've heard yesterday with what goes on today. So I think one of the underlying themes and questions that have constantly been coming up is that the new guidance, in some sense, assumes that there are distinct risks that are associated with research that aren't in actual care. And I think yesterday and today, we've had a lot of discussion about, is difference the same as risk? And whether or not differences should be considered harms or discomforts. And so I was wondering if we could begin to address whether or not there is additional risk in being in a research study, and how we help OHRP distinguish between what may be a risk of harm or discomfort versus a difference or an alteration, as some of our other speakers have spoken about. So I think that's the first thing we need to talk about. And implicit in that is this notion of whether or not random assignment is in itself a risk. Well, I would start with the notion of, is random assignment, what is it about random assignment that may be risky? We've had a number of people who talk about preference. Now, one of the things that occurred to me is when you give somebody informed consent and tell them they may be randomized to one condition or another, they actually are expressing preference. They're expressing a preference of whether or not they want to be in a study in which they're randomized versus choosing, hopefully with their physician, one arm or the other. So what makes random assignment more risky? And is embedded in this concept of random assignment the notion of the rigidity of a manualized treatment? And should that really be distinct from this definition of randomization?
So I think you can actually ask the opposite question, and that is that randomization removes some risk. So for instance, if there's not evidence to choose between one versus another therapy, then a patient is being provided that recommendation based on sometimes a great number of biases or opinions that aren't based in evidence. So one key concept with randomization is the fact that it eliminates some of that. It doesn't let a provider or a patient or anyone influence the choice of two different treatment arms.
Yeah, what I would say, I mean, my reading of so first of all, I agree with that comment, but I'd also say that what my reading of the guidance was not so much that it necessarily increases risk, but that it distributes the risk differently to individuals. And that's pretty hard to argue with, because if you have A and B, and A causes headaches and B causes toe pain, and a person could choose to have headaches or toe pain if they were choosing, but now you're going to randomize, that distributes risk differently. And I think my sense is almost everyone in the room would agree that if you had infinite time, you would love to go through all toe pain and headache issues on every possible treatment. But I just want to keep insisting that there are many critical questions where to do that would cost tens of millions of dollars. and that we have to come up with alternate ways of thinking about describing the redistribution of risks.
Sorry, go ahead.
I mean, I also think, I think there's two ways to think about whether there's increased risk in being in a study. One is empirical, by looking at actual data from people who have been in studies compared to people who have not, and that data is pretty clear. It doesn't increase risk. The other is conceptual. To make the assumption that it necessarily increased risks is to assume, as I suggested in my little parody of the way people think about clinicians, that the decision your clinician makes for you will always be the lowest risk state, so that any alteration increases risk. And that's an unlikely situation given what we know about practice variation.
I think that the issue of randomization cuts across certain values that are widely held in our society. And whether or not you want to call it risk or not, I think is debatable. I think the key issue is the decision that there truly is equipoise between standard A and standard B. We allow people, or we give people, the opportunity to choose something like 75 different breakfast cereals, which distributes the risk of sugar, fat, God knows what else, in a different way. A society that had 3 cereals might arguably have some great benefits over this. So in the same way, I think the issue is, with randomization, more about the value of choice which individuals could give a particular weight, high or low.
Following up on the value of choice is this notion that if you, and this goes back to the point that Valerie made, that if you are not randomized, that there is not some, not a cryptic randomization, but the term that Rob used yesterday, somebody is making a choice based on some kind of perception or bias. So thinking that randomization is other and dangerous seems to me to be sort of at odds with what's happening absent randomization, and that we have to sort of come to this from this, not from this position that we have to defend randomization because it is other or different. Randomization is going on all the time, with or without our knowledge or consent. So I think part of it is framing the conversation about randomization.
I think there's also group risk and individual risk. And when you look at the meta-analyses and there are worse outcomes for people who've been randomized, I mean then that's true at a group level that the outcomes haven't changed. But if you assume, and one would think that the reason you're doing standard of care research in the first place is because one of the treatments may be better, and you're hoping that you'll find a difference, and you'll find out which one's better or less harmful. So some people who would have gotten the better treatment at an individual level are now going to be randomized to getting the worst treatment, and vice versa. So at a group level, even if those two things even out in the end, for an individual, you're taking a different risk than if you just follow your doctor's advice. And I think most people want to believe, correctly or incorrectly, that they have found a physician that they trust or that has been recommended to them, and that they're comfortable with this person's biases, even if they don't recognize them as biases, and they're willing to cede, this is an individual that I trust to make this choice for me. And then when they're told, do you consider me randomized, it's a completely different proposition, and I think they have to understand fully in that kind of situation what the risks are and what they may or may not be exposed to as a result of that research study.
So I agree with what you said factually, and I think the real issue is how do we interpret it and act. And the things that that are really driving me are we know that deeply embedded in this physician-patient relationship now is a great reluctance of health systems and physicians to admit they don't know. Because we're in a competitive society where if you pretend like you know, even if you don't, you do much better in attracting referrals. Anyone that runs a high-end referral practice, as I used to do, also knows that there's almost no correlation between a physician's ability to engender trust in a patient and their actual knowledge of what's best for patients. In fact, many of us have felt for years there's an inverse relationship because building trust in some ways, the way the interactions happen, means glossing over uncertainty. And so we end up with an argument fundamentally, in my view, for ignorance. That is, it's better to not know and to pretend like we do than to say, we really don't know. It's okay for you to choose to help us find out or not, which is what I heard Lantos state very clearly.
So this is another example where I think thinking about cluster randomization helps me understand whether randomization increases risk. Let's do the thought experiment of a health system that has 100 hospitals, and it makes a decision that it wants to implement a new ventilator care program that involves a whole variety of components, including different medications. It would take a while to roll this out. Let's say it takes 2 years to roll it out through 100 organizations. According to Susan Ellenberg, if they choose their hospitals alphabetically to roll that out, that's not randomization. It's just the way they choose to roll out a new program. If they randomize the order in which they roll this out to their 100 hospitals, they would learn an enormous amount about whether the new regimen is different, better or worse, by how much than they would if they use some other mechanism. Are they doing research now? Is there a different risk that's been assigned? And B, whether there's a different risk or not, I don't think there is. Are they under some new oversight regime because they randomize the order in which they roll out a process that they've decided they'll roll out to everyone? So I'd say the answer is no. Randomization doesn't increase risk by itself.
And I would just like to add an observation that's just come to me in the last few days as I've thought about this issue. It's a bit tangential to the question, but not totally so, I think, and I forgot to mention it earlier. And that is this idea that most of the benefits from this kind of work accrue to future patients and those who care for them. I think that's our default IRB assumption, at least at my place, is that most research that's going on, most clinical research, the benefits mostly are going to accrue in the future. And I don't think that's always true, and I think it may be less true in the kind of research we're focusing on in this workshop. For example, if you have a chronic disease condition that's expected to go on for many years, your own care may be a lot better as a result of the results of the study. And as an example, kind of maybe a crude one, but if you were in the CAST trial and you survived to the end of the trial, you benefited by either being taken off of harmful therapy or not getting harmful therapy in the future. Another example that I used to use in my own research in kidney transplant patients is, unfortunately, today, a good 10 to 20% of people who get a first kidney transplant end up needing a second or even a third in the future. So if we know how to do a better job in the future, that may help them, not just people coming along in the future.
John.
I agree that randomization generally doesn't increase risk. That doesn't mean that randomization is not abhorrent to many people for all sorts of other reasons. And so the question of whether it increased risks and the question whether it needs to be disclosed and people's consent obtained in order to be randomized are totally separate questions. When their consent is obtained, it should be explained to them that this is not likely to increase risk, but it will change other aspects of your care, including perhaps the likelihood that you will have a harm or a benefit that you might not have had if you weren't randomized, but we don't know whether you might have the harm or the benefit. I mean, the analogy I always think of is to investing in mutual funds, which is similar to doctors. I mean, all the studies show index funds do better than managed funds, but people who manage funds make a lot of money by pretending to know more than the indexes do, and lots of people spend money to get a worse product. That's true in medical care as well.
Could I just say, I agree fully that all learning activities should be disclosed. I mean, I think that's but I think that's true of quality improvement activities. It's true of the wide range of clinical activities. The disclosure requirements should be much greater than they are now, and they should be uniform, I think. And randomization clearly is part of that.
I think one of the problems in our discussion, though, is that, so we express the ideal for what I call old-fashioned research, which is generally too small to actually answer a question and change practice. The minute we scale up to the sample sizes needed for most treatment effects, you run into, I mean, Rich was very involved in the hospital study that we talked about, you know, disclosing all the risks to 400,000 people in a randomized trial that has a huge public health benefit when it's done is not feasible. So somehow that has to be dealt with in this thinking.
I mean, it's beyond that. That trial that you're talking about is one in which hospitals adopted a practice. The individual patients had very little opportunity to choose something different. I mean, technically there were ways to do it, but basically you have to get your care somewhere else if in those situations.
Okay, let me shift to another question also that kind of implicitly came up yesterday, but wasn't followed through. And that is the question about whether or not standard of care research is minimal risk because it's standard of care. And I was thinking how interesting this is because in some sense it's assuming a relative or health or patient-oriented definition of minimal risk, right? Usual routine care, rather than a uniform, the healthy person definition of minimal risk. And this becomes important in terms of the notion of whether or not there are elements of informed consent that can or cannot be waived. So I'd like some of you to address, just because it is standard of care, does that make it minimal risk in terms of our regulatory definition?
John and I are currently writing a paper on this, which will be heavily scoured by another 200 ethicists and others the first week of January in Baltimore. And I have to say, as not being an ethicist or an IRB member, as I talk to a lot of people, the regulatory definition is so vague. I don't have much use for the minimal risk term, but it seems to me that probably there's agreement that if it's standard of care, the total risk is not increased, as we've just been discussing, but the distribution of risk is changed. And what that means for whether, John actually rewrote my first version of the paper because I started out with, the only reason we really care about minimal risk is so you can waive or alter consent. And he said, no, let's start on the non-utilitarian side and talk about the concept first. But, you know, what does that mean about waiver of consent? I hope the panel will weigh in on that, or alteration of consent.
I was just going to say that as I was running through quickly, the examples that we have, the classical examples where standard of care turned out to be a problem. That in fact, in those classical examples, the one being oxygen for retinopathy of prematurity, that in fact, you identify risks that you had not identified before. So if everybody is getting standard of care, then everybody's going to continue to get that. There's really no benefit. I mean, the benefit is there whether you're in the trial or not, but we do sometimes identify major risks that would have been missed if we had not done the trial.
Yeah, I'd just like to follow up on Robert and Ed's comments. You know, we use this word standard of care, or this phrase. In fact, it's not necessarily ever true, at least in the many of the disciplines we have where we're using drugs that are off-label. The other thing I think is important is what you determine in a trial in one set of conditions in patients is not necessarily transferable to another. And there are many examples between adult trials and pediatric trials going in both directions where the results of that trial were not transferable to another. So if you were to present this is the standard of care with this particular drug in this setting, that is in fact based on a totally erroneous example. So I think these are important nuances to this framing of standard of care.
I want to follow up with that as a question of, is research that's looking at the ends of the typical standard of care continuum, standard of care research?
I would say if it's randomizing the two ends of a spectrum, I would have a hard time calling that standard of care research. But it's been interesting in these 2 days. I've heard people rail for and against more precise nomenclature. I actually really believe that good naming things, something that everybody agrees to, is really important. Even if you end up saying, now that we understand what we're calling it, we don't need to talk about it anymore. But to me, standard of care research, the way most people think about it, is comparing one practice to another that are holistic, not randomizing to extremes.
So I would like to borrow or steal a way of looking at this that I think came mostly from Jeremy Sugarman yesterday, which is that I think it depends on very much on the nature of the study and the alternatives. If they're really quite qualitatively different and the risks are very qualitatively different, it becomes harder for me just sort of at the gut level to say that that's minimal risk. But on the other hand, I think there are other times when that's less so. Like the definition that we currently have in the regulations focuses on whether things are in the realm of everyday experience, normal physical exams and psychological exams. I guess it doesn't really say normal medical treatments or anything exactly like that. Maybe something like that is what we need.
Well, specifically, it doesn't say whether it pertains to healthy people or people with a disease that's under study.
And that would-
IRBs are disagreeing on that point.
So most of what you're talking about, though, where minimal risk comes up in the regulations, is for judging whether studies can be done in children that do not have therapeutic intent.
That's for children, but there are a lot of adult studies that do.
But I think what's more relevant for standard of care studies is not whether they're minimal risk, but whether the risks and benefits are balanced, which is a different measure altogether. It makes it harder to alter or waive consent, as it should, but the relevant feature for altering or waiving consent, I think, is whether consent should be whether consent is feasible. Not whether risks and benefits, that is, the fact that risks and benefits are balanced doesn't justify altering or waiving consent if consent is feasible. Balanced risks and benefits might permit altering or waiving consent if consent is not feasible.
This is actually, I think, a very important point relative to the impact of the guidance. So I just want to make sure I'm understanding what you're saying, John. I mean, what I've been taught by all your colleagues is you don't get to feasible until you've gotten by minimal risk. So in other words, if you don't get by the minimal, this is really...
This would be a good one to open.
Yeah.
There's a lot of expertise out
Well,
here.
I think that we're really kind of focusing on 116 or whatever, and yes, that's true, and that's what we were trying to talk about, because I think that's where the issue comes up, because you really can't even begin to discuss waiver until you determine that it's minimal risk, and then you decide whether or not it's feasible to conduct it. And then I think, as Nancy pointed out yesterday, you also have to decide whether or not there are adequate protections for the other rights that participants have. So it's a useful discussion around waiver of informed consent. So let's just move there for a moment. Is it ever appropriate? Are there situations in which it is appropriate to waive elements of informed consent for what we're not sure is standard of care research? I think that Ruth gave some good examples yesterday when she was talking about the informed consent, and basically the risks and benefits were, there's no difference between the risks and benefits of what you might be offered anyway. And so in some sense, that's a waiver of information about the risks and benefits. So is there any aspect, does standard of care research, is it unique in any way that there are certain aspects of informed consent that can or should be waived?
I can maybe give you a real-time example. So the treatment of status epilepticus in children is using drugs that are off-label, all of which have significant side effects. And depending upon which emergency room you go to, you will get a choice. And so there is now a trial that is being conducted where there is random assignment and there is no consent that's done a priori before the drug's given. So it's trying to answer the question, what is the best anti-epileptic drug for a seizing child in an emergency situation that will give the best outcome? And the evaluation of, significant risk in the child, of significant sequelae, not knowing what the right drug is, but the belief was through a very complex review process that this was in the best interest of gaining good evidence to direct good care.
And I'm guessing that part of the calculation was you couldn't get consent in those circumstances.
Yeah, and emergency
Exactly.
research, there are
Exactly.
guidelines for
Exactly.
that. So
Not
that's
that it's
different.
minimal risk.
Not that it's minimal risk.
But
But that got out on the emergency.
That's an emergency research exception, right.
But it seems to me the general answer has to be yes. I mean, it has to be the case that so many of us have said context matters, that it can't be that consent has to be the same in every circumstance. And I think the answer to, well, how should it change and under what circumstances can be the subject of empirical research.
I think, and Marjorie just raised the point, that in terms of harmonization and depending on OHRP guidance, that FDA does not allow such waivers. And so we have to be careful thinking about that. And I think that the waivers that have been discussed specific to standard of care are waivers regarding risks and benefits, and what are those in the research itself that are independent of the care.
Actually, FDA is pretty clear that if you use a drug in a way that it is labeled, then all those rules don't really apply. At least that's what I think I've heard them say. So we don't have to be so concerned if we're really talking about treatments used in the way that they are currently approved by the agency.
But isn't just, and I don't know the answer to this, but I thought a lot of standard of care is off-label use.
So, I mean, my comment to, I don't want to get into the Rich and Rob show here because we argue all the time, but what Rich says is true if you talk to the right person at the FDA. It's not true if you talk to the wrong person at the FDA.
And part of this, when you get into the weeds of whether we're following regulations of FDA and OHRP, gets into compliance and gets away from maybe what I would call ethics. That is, if you get the right person at the FDA and you have your lawyer who can negotiate, you can, I mean, we're doing studies on whole genome sequencing in newborns, and one of the sites got an FDA approval and one of the other sites didn't. Why? Who knows? They're doing the same thing. It might have been the person who they got at the FDA that day, or what, but so I think there is a good example, though, of how this works in other countries where they aren't subject, and that's the TASTE study that was done in Sweden of interventions for adults with acute MI. And the question is, you probably not, I'm going to get this all wrong because I don't know what an adult is, much less an MI. I'm a pediatrician. But the question is whether you should suck out the clot or push it out of the way when you're doing the emergency intervention. And what they did was a brief 2-paragraph oral consent, where when people came in with their crushing substernal chest pain, they said, docs disagree. Some say push it out of the way, some say suck it out. Would you agree to be randomized? And if not, you'll go to a doctor and they might push it out of the way or they might suck it out. And 2/3 of the people said, okay, I'll be randomized, and 1/3 said they didn't. And they got data on both. That was great. You couldn't do it in the United States, I don't think.
Just to add tragedy to the
But
irony,
you should be able to.
those folks did a sabbatical with us for a year to learn the methods and went back. They couldn't do it. in the
Okay,
US.
Marjorie?
So just to clarify, the reason I brought up the FDA regulations is because they are different from the OHRP, and one significant area where they're different is on this topic of informed consent. And to clarify, if it is medical practice, that the FDA regulations do not apply in that situation. But much of, I suspect, or some of the standard of care studies and research that we're talking about could lead to changes in the labeling of drugs. And in that case, it then becomes an FDA-regulated study as well as one that is regulated by OHRP. And this guidance, that we're talking about is just OHRP guidance, not FDA. So we just want to be cognizant, I think, of that as we have this discussion.